Good day. I am Dr. Kristy Taladua, an infectious diseases specialist. I am here to talk about monkeypox, specifically for clinicians. I have no disclosures, and this is the outline for my topic. First off, just a quick background on how monkeypox became a concern globally. In May 7 of this year, there was a reported case of monkeypox in the UK, which quickly garnered increasing cases over the course of the month. Later on, with more detected cases identified in the US and quickly spread to other non-endemic countries in the world. So a discussion on the origin of monkeypox, it was first detected in 1958 in Copenhagen by von Magnus as an example of primates in captivity. By 1970s, there was the first detection of the monkeypox in humans in Africa, specifically in the Democratic Republic of the Congo, in a 9-month-old child while doing surveillance activities for smallpox. By 2003, there was first detected human monkeypox infection in the United States. And it was a result of exposure to ill prairie dogs, probably infected after exposure to infected West African small mammals imported as a supplement. Monkeypox has been endemic in Africa since the 70s, and they have outbreaks of which the most number of cases was in 1996 to 1997, with more than 400 cases reported. And then clusters of reported cases in the 2000s, of which were mostly children aged 15 years old and below. In 2017 to 2018, however, there was an outbreak in Nigeria where most of the cases were young adults. So a write-up was published in Lancet around 2019, which summarized that the outbreak of human monkeypox in Nigeria was to some extent unexpected and suggests changes in monkeypox virus epidemic dynamics in West Africa. The determinants of human monkeypox emergence in Nigeria, including distribution of animal reservoirs and changes in human behavior, need to be identified. So from 1970 to 2021, these were the only countries with reported monkeypox cases, Africa being an endemic area where the infection was locally acquired. The US, the UK, Singapore, and Israel had confirmed cases, of which were all imported. For this year's timeline, in May 7 of 2022, a patient was treated for monkeypox in the UK by a specialist after returning from travel in Nigeria. This was the first case documented for the year 2022 regarding monkeypox infection outside Africa. By 19th of May, 2 new cases in the UK with 70 suspected cases in Canada, 14 other cases in Portugal, and a confirmed case in Italy was reported. And the first case of monkeypox infection in humans for the year 2022 was reported also in the US. So by end of May, monkeypox reached Latin America with reports of 1 death in Nigeria. Cases continued to rise globally with more detected cases in the US that by June 25, the US started its vaccine rollout. At this point, though, WHO determined that monkeypox is not a public health emergency yet. There were 2 more deaths, however, that was reported in Africa in the first week of July. Hence, WHO revisited its earlier decision regarding monkeypox as a public health emergency. The following week, there were already reports of first cases in India, Russia, and Saudi Arabia, as more countries reported their first monkeypox detected cases in humans, and the cases continued to rise. With Thailand, Japan reporting its first cases, and then finally by the end of July, around July 29, Philippines had its first reported case with reports of deaths that week in countries um, from Brazil, Ghana, India, and Spain. So at this time, the U.S. also declared monkeypox as a public health emergency. So, however, in the first week of August, there was a slowing down of the cases in the UK, and by the first week of September, there was also declining cases in Spain, but there were still new countries reporting their first case, such as that in Hong Kong. So as of September 6, 2022, globally, there are around 54,175 confirmed cases with monkeypox, and 18 of them were confirmed to have died, and 92 countries have confirmed cases already for monkeypox. So this shows countries with confirmed cases of monkeypox since January 2022. And this data from monkeypox.global.health as of September 2022 shows the top 10 countries with the most cases of monkeypox, of which United States is still number one. Philippines is currently at number 71 with 4 confirmed cases. So for its morphology, monkeypox is under the genus orthopox virus and under family Poxviridae. So aside from monkeypox, other orthopox viruses include your vaccinia, cowpox, camelpox, variola, or smallpox. So it is a very large envelope, quick-shaped virus. It has a linear double-stranded DNA, and its replication is in the cytoplasm. So the monkeypox has 2 genetic clades, the Central African clade and the West African clade, now called clade 1 for Central African clade and clade 2 for West African clade, to avoid geographic references and potential discrimination. So for your clade 1, the infectiousness its transmission can survive up to 7 generations, and it has a higher case fatality ratio of up to 11% compared to your clade 2, which has a limited infectiousness and its case fatality ratio is only up to 6%. Grade 2 is further subdivided into 2A and 2B. And currently, genomic sequencing shows that predominant orthopox virus in the current worldwide outbreak comes from your grade 2. So, but interestingly, the infections in the current outbreak survive up to 6 to 9 generations of transmission, contrary to the previous data about its limited transmission. So, monkeypox is a virus that is zoonotic. So though named monkeypox, monkeys are not the main reservoir of the virus. Rather, the virus is believed to mainly reside in rodents, including squirrels and rats. The natural host remains to be unknown. Non-human primates are susceptible to monkeypox virus. Primary infection, which is an infection from animal to human, happens when a human gets into contact with an infected animal or contact with contaminated animal products. Secondary infection is human to human, which occurs through close contact with infected people through droplets and skin lesions, direct contact with body fluids, contaminated bedding or blankets, prolonged face-to-face contact, and probably sex. Though this is confounding since there is skin-to-skin contact during sex. Secondary infection also occurs from mother to fetus. This is a congenital route. Clinically, this slide shows the overview of the disease progression. We have the incubation period, the febrile stage, the rash stage, and then the recovery. So the incubation period is the interval period from infection to onset of symptoms of your monkeypox, and it is usually from 6 to 13 days, but it can range from 5 to 21 days with a mean incubation of 8.5 days. At this period, there are no symptoms. The virus can be present, but at the end of the incubation period, this is known as your viremia. So the infection can be divided into 2 periods, the invasion period or febrile stage, and the skin eruption or the rash stage. The invasion period lasts between 0 to 5 days, and some studies around 1 to 4 days. There's characterization of fever, intense headache, lymphadenopathy, back pain, myalgia, intense asthenia. And for this stage, lymphadenopathy is a distinctive feature of monkeypox compared to other diseases that may initially appear similar, such as your chickenpox, measles, and smallpox. The lymphadenopathy is usually found in inguinal and cervical regions. The rash stage, or the skin eruption, usually begins within 1 to 3 days after the appearance of your fever. The rash tends to be more concentrated on the face and extremities rather than on the trunk. It affects the face 95% most of the time. It also affects oral mucosa, genitalia, conjunctiva, and the cornea. This virus is present already in the skin lesions, and the antibodies are produced and become detectable. So this shows the evolution of the monkeypox rash. The rash evolves sequentially from macules, papules, to vesicles, to pustules, and to crust, which later on dry up and fall off. So the number of lesions varies from a few to several thousand. In severe cases, lesions can coalesce until large sections of skin slough off. The lesions are generally deep-seated, circumscribed, vary in size. They may be umbilicated, and it can cause itch or pain in the entire process, and it can last for around 2 to 4 weeks or longer. In a published article in One Health, this is an example of the lesions, which later on become umbilicated. So you have here your body lesions from over the course of time. Take note, these are not only seen in the body, in the face, but it can also be seen in the genitals as well as in the anal area. So monkeypox should be differentiated also from the other common rash illness, such as your chickenpox and measles. The rash in monkeypox compared to chickenpox are often in one stage of development, and its development is quite slow. So as mentioned, the presence of lymphadenopathy is apparent in monkeypox, and monkeypox death rate can be up to 10% depending on the clinic. Just a quick comparison with smallpox, though smallpox has already been eradicated, the reservoir for your smallpox are humans compared to monkeypox, which is zoonotic. Fatality rate is 30 to 50% in smallpox, while the fatality rate of your monkeypox is around 1 to 10% of the cases, depending on the strain or the clade. So if you can see, they almost have the same vaccines actually, because the monkeypox vaccine is based on the smallpox vaccine. So other differentials will include your bacterial infections such as Staphylococcus aureus infection, other viral infections such as hand, foot, and mouth disease, shingles, herpes simplex, STIs such as chancroid in the genital area, and genital herpes. You can also have secondary syphilis, disseminated gonorrhea, and papilloma acuminata. So this table shows, I'm sorry, there are novel and atypical presentations currently with the new monkeypox. So just for the 2022 monkeypox, it was noted that there were atypical presentations. So most of the patients had 10 or fewer lesions. So they sometimes present with fever, and some of them do not have any fever at all. So these few lesions are mostly discrete and frequently pustular with umbilication. The classic rash progression and the classic distribution that we discussed a while ago may not be present in these patients. So there's also a report that there's an absence of prodromal symptoms such as your fever, the body malaise, and everything And there are also reports that they occur, these prodromal symptoms occur after the appearance of the rash. So you can look up these descriptive case series published in Lancet, and also you can check out the SMID updated guidelines on screening and detecting monkeypox virus infections. So this table shows the difference in the signs and symptoms from patients in London in 2022 compared to those previous reports in DRC. So they found out that the lesions are the same, they're still macular, papular, and they can be umbilicated. However, in the London cases, they found that the maculopapular lesions are more widespread, and the lesions are um, less in number. So the mean count of the lesions in the London cases are only around 6 compared to that in DRC, which is in the hundreds. So the mean count is at 370. So the lesions found in the London cases were present at different stages simultaneously, and not all lesions progress from one phase to another in order, compared to your classic presentation found in the DRC cases where progression from one phase to another occurs in order. And this time around, most of the lesions were found in the genitals and perianal in the London cases compared to head and arms in DRC cases. So in terms of systemic symptoms, fever and lymphadenopathy are the top symptoms that the patient feels um, or has, and also myalgia compared to the DRC cases where they usually have the less fever, chills, and of course lymphadenopathy. Most common localized symptom though for the monkeypox 2022 is rectal pain because of the anal lesions, and then sore throat and renal edema, compared to those in DRC and even in Nigeria, where they mostly complain of sore throat. So this is just an example of a typical presentation in a case of an MSM who had a sexual contact and it was an unprotected sex. For this, there was an evolution of cutaneous lesions, which first presented in the foot and later on the hand with very isolated lesions. So the first symptom that the patient felt was fever and lethargy, and a day after, he developed one lesion in the foot and a lesion in the finger. He underwent testing, and the PCR test turned positive for monkeypox. On the second to fourth day of the illness, he developed two more skin lesions, but after that, there were no more accounted lesions. And by the fifth day, his lethargy resolved and the patient recovered. So to date, the current spread has disproportionately affected men who are gay or bisexual and other men who have sex with men, which suggests amplification of transmission through sexual networks. Most are males with a mean age of 41 years old in confirmed cases. So complications include pneumonitis, encephalitis, keratitis, and secondary bacterial infections. So this table shows the risk factors and clinical findings that might be associated with a more severe disease and a poorer outcome. So those who are in the high-risk groups that can have severe diseases or complications are children, pregnant women, persons who are immunosuppressed or immunocompromised hosts. Um, though lacking in data, uh, patients who have chronic skin conditions can also have complications because they are at a higher risk for a superimposed bacterial infection. Um, Clinical signs and symptoms that uh, can have a severe or can lead to a poor outcome uh, includes nausea and vomiting, painful cervical lymphadenopathies that can cause dysphagia, poor oral intake, eye pains, and vision abnormalities. Those with respiratory distress or pneumonia and or CNS presentations such as your confusion. Laboratory abnormalities include your elevated hepatic transaminases, low BUN, low albumin, elevated WBC, and low platelet count can lead to a poor outcome. By skin lesions, uh, based on the smallpox experience, the disease can become very severe if the patients are more than 250. So this has a poorer outcome based on the studies. Other risk factors include an invasive route of infection, and if it is a Congo Basin trade variant or trade 1 strain that has infected the patient. So for the tools and guidelines, um, first off, we need a good screening checklist that should be implemented in areas providing frontline medical services. So we should screen our patients, especially in the wards, emergency rooms, doctors' clinics, most especially in HIV and STD clinics. So this is a very good example of a checklist uh, in PCMID updated guidance on screening and detection of monkeypox. So if the answer here in number one of a person having a rash is already yes, then an additional other answer from the items below it can you can already make a consideration of a possible monkeypox. So symptoms would include the like, and most especially if patients have a travel history or have history of contact with another person with rash or um, with sexual contact. So in evaluating suspected cases, the recommended set of personal protective equipment includes your face shield or goggles, an N95 mask, a disposable gown, and disposable gloves. So the risk of transmission is low during the prodromal period until the rash or the oral lesions appear, and isolation is at least 21 days or until the resolution of all symptoms, including any rash, crusting, or scabs. Until the scabs have separated, they have fallen off, it shows an underlying skin that has healed. So either whichever is longer should. So this is the case and contact definitions from DOH. They you can classify a suspected case based on this definition when a person of any age presents with um, monk, an unexplained rash and with the following signs and symptoms: headache, fever, and the like. So for which the following common causes of acute rash do not explain the clinical picture, such as the varicella, zoster, herpes zoster, etc. So it becomes a probable case when it meets the definition for a suspected case and there is an epidemiologic link or to a probable or confirmed case of monkeypox in the past 21 days, or reported travel history to a monkeypox endemic country in the 21 days before symptom onset, or has had multiple or anonymous sexual partners in the 21 days before onset. A confirmed case is when the case meets the definition for either a suspected or probable case with a laboratory confirmed detection of their monkeypox virus through real-time polymerase chain reaction, or PCR, and or a whole genome sequencing, or WGS. So it's a discarded case if the case meets the definition as either a suspected or probable case, but the test turns out negative through RT-PCR or WGS. So contact is defined as a person who, in the period beginning with the onset of the source case's first symptoms and ending when all scabs have fallen off, has had one or more of the following exposure: a face-to-face exposure, direct physical contact, including sexual contact, and contact with contaminated materials such as clothing or bedding. So for the diagnostics, the preferred laboratory test is the real-time polymerase chain reaction, or RT-PCR, because it is accurate and it is sensitive. It is here in the Philippines, it is being sent out to RMDM. Take note that the monkeypox virus is a DNA virus. So the PCR here that is being used is the real-time or your conventional PCR. Compared to your SARS-CoV-2 or your COVID virus, SARS-CoV-2 is actually RNA. So the RT there in your RT-PCR is reverse transcription PCR. So those two are different. So the optimal samples are your skin lesions, so the roof or the fluid from vesicles or pustules and the dry crusts, and oropharyngeal swabs can also be taken. So serum PCR is inconclusive and should not be routinely collected because they 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 um, they are not usually done. So for those this is just an example for the primer or the probe sequences that is being used in PCR tests to detect your monkeypox virus genes. So for the another diagnostic is an electron microscopy, which is no longer routinely used due to the availability of molecular assays. It is not monkeypox specific though, so it's no longer used. Viral culture can also be done, but it is not recommended as this procedure takes time and it is resource intensive. It should only be performed also in laboratories with appropriate experience and containment facilities. How about how about immunological methods? So you have your antibody ELISA and antigen LFA. Your ELISA is a test that tests for the presence of anti-orthopox virus antibodies. This is not recommended because of its extensive antigenic cross-reactivity among orthopox viruses. So it is unable to distinguish previous exposure from smallpox vaccination or other orthopox virus infections. Your antigen LFA can also test for your monkeypox virus or orthopox viruses. However, this is less sensitive than your NAT or your PCR, so this is also not recommended at this time. So what are the other diagnostics that you can use to rule out other illnesses? You can have your varicella, which can rule out your chickenpox, rubella, rubiola for your measles, Gram-stain culture sensitivity for bacterial infections, RPR, PDRL, TPPA for your students. So for the management, first things first is to check for biosafety and assess the biological risk. So safety procedures must be ensured and laboratory personnel must be trained for appropriate donning and doffing of PPE, specimen collection, storage, packaging, and transport. All specimens collected for laboratory investigation should be reported as potentially infectious and handled with caution. Measures should be taken to minimize the risk of lab transmission based on risk assessment when testing routine clinical specimens from confirmed or suspected monkeypox patients. So strict adherence to infection prevention and control guidelines must be ensured during specimen collection and handling. Take note when handling suspected patients who have monkeypox virus, they should be placed in contact and droplet precautions. For those that will undergo aerosolizing procedures, an airborne precaution should be in place. So this is a step-by-step instruction on proper specimen collection from ritm.gov.ph. You can visit this site and it has a demo video and instructions on how to collect the specimen as well as packaging and transport and transporting the referral samples to RIT. So for the treatment, it still remains supportive and symptomatic, and currently antivirals have an ongoing study. So since we are managing patients based on their symptoms, we treat their condition uh, and with care and monitoring. So for example, if the patient has fever, then your objective there is to prevent and treat further complications, give external cooling, antibiotic medications, and regular temperature monitoring. That goes for the others as well as your skin infections, exfoliation, skin compromise, eye infection, mouth and throat sores, vomiting and diarrhea, most especially where they have fluid losses. So food and fluid intake and output should be monitored. For patients who have these symptoms, you can give IV rehydration or antiemetics. Just make sure that you don't use much of your anti-motility since these medications can cause abuse. So for pain, patients who are complaining with pain, such as those who have painful lymph nodes, those who have mouth and throat sores, you can give them oral or topical analgesics or anti-inflammatory medications. Those that are severe, such as those who have respiratory symptoms or are in distress and are already septic, then you can follow the guidelines that, in managing these cases. You may use oral and intravenous antibiotics based on your assessment and oxygenation as needed. So for the cases in 2022, most of the patients really complain of anogenital lesions and proctitis or urethral pain. So for anogenital lesions, you can instruct them to do a warm sitz bath that can lasting at least 10 minutes several times per day, and give topical benzocaines or lidocaine gels or creams that at the recommended dose. You may also consider topical acidoplovir for severe localized lesions. For the proctitis, you can give it stool softeners, also instruct them on sitz bath, give oral pain medications and opioids, and you can also give topical lidocaine. How about the antivirals? Currently, there are no antiviral or immunoglobulin treatments that has been approved globally as per DOH. Even in CDC, there is no treatment approved specifically for monkeypox virus infections. Those that are developed were initially for smallpox. So who are the patients that we can give antivirals? So we can consider them in people with severe disease, such as those with hemorrhagic diseases, sepsis, encephalitis. People who have maybe at high risk of severe diseases, as the one that we discussed a while ago, and people with monkeypox virus aberrant infections that include accidental implantation in the eyes, the mouth, or other anatomical areas where monkeypox virus infection may constitute a special hazard. So these are the current antivirals that are being used for cases of monkeypox. First is Monkeypox. It targets and inhibits the activity of the orthopox virus BP37 protein and blocks its interaction with cellular Rab9 GP-base and TIP47. This prevents the formation of egress-competent envelope variants necessary for cell-to-cell and long-range dissemination of the virus. So this is the recommended dose. Currently, it's already in the phase 3 clinical trial for your monkeypox. Its approval is based on animal models, and it has an expanded access or compassionate use in the US. The next antiviral is rosidophilvir. This is actually being used as treatment for your CMV or your cytomegalovirus. It acts as a competitive inhibitor and alternate substrate for CMV DNA polymerase. So this is the recommended dose. But currently, there's no human clinical trial for monkeypox using cidofovir. It is only based on in vitro and animal studies that it was seen that it can be effective against orthopox viruses. It appears to be most effective in given early after a monkeypox exposure in some animal trials. The next antiviral is brincidofovir, which is a prodrug of your cidofovir. It almost have this same mechanism of action as your cidofovir. The recommended dose is as follows, and currently it is FDA approved since 2021 for the treatment of smallpox. It has limited data for monkeypox, however, and in case reports by Adler, they reported that there was cessation of this therapy due to development of elevated liver enzymes in these patients. The last one is your vaccinia immunoglobulin or VIGIV. It provides passive immunity, and its exact mechanism of action is not formally known. The dose is as follows, and it is FDA approved for smallpox. CDC holds an expanded access protocol that allows the use of VIGIV for the treatment of orthopox viruses, including your monkeypox in an outbreak. Other ways is to vaccinate people so that you can prevent further transmission of the disease. The current vaccine that is being used is Jynneos, also known as Imavune Invanex. It is approved for prevention of smallpox and monkeypox, and it is the primary vaccine being used in the US during this outbreak. So it's a replication deficient smallpox vaccine, and attenuated live virus vaccine can be given to 18 years old and older with a two-dose series given 28 days apart. It is given subcutaneously, and it is 85% effective in preventing monkeypox. You are considered vaccinated 2 weeks after the receipt of the second dose. The alternative to the Jynneos vaccine is the ACAM 2000 vaccine, which is approved to help protect against smallpox. And currently, this is also being made available to prevent monkeypox. It is a live replicating vaccinia virus vaccine, and it can be transmitted to persons who have close contact with the vaccine. Single dose given by multiple pricks to the skin using a special needle is a route. and the person is considered vaccinated against monkeypox 28 days after getting the single vaccine dose. So in vaccination, when to vaccinate? So we vaccinate pre-exposure in groups at high risk of occupational exposure, especially those who are handling laboratory materials in processing the samples, post-exposure in close contacts of infected cases, preferably within the 4 days of exposure. So who do we vaccinate? Selected persons at risk for occupational exposure may be vaccinated, such as those who are in the research laboratory personnel. Close contacts, especially those who have unprotected direct contact or in a high-risk environmental contact for monkeypox virus, can also be vaccinated. So the best way to prevent transmission is to continue our surveillance and rapid identification of new cases. So close contact with infected persons is still the most significant risk factor for monkeypox virus infection. And healthcare workers caring for patients with suspected or confirmed monkeypox virus infection or handling specimens from them should implement standard infection control precautions. Currently, the R naught is estimated at approximately 2.1. That means that one infected person spreads it to approximately two others. So who should we monitor and for how long? Anyone who has been exposed to people or animals with monkeypox should monitor their health or be monitored for signs and symptoms consistent with monkeypox for 21 days after their last exposure. All close contacts should be quarantined, monitored for signs and symptoms of monkeypox. If there is a development of rash or of any sign of symptom, and they are under quarantine, they manifest the signs and symptoms of monkeypox, they shall be immediately transferred to the dedicated referred hospital for treatment. This is under our DOH guidelines. And for those who are under quarantine, who manifest signs and symptoms but are not related to monkeypox, they should be treated on site by a licensed physician and may be referred to an ID specialist if necessary. So for the outcome, we've already discussed the disease progression from incubation to prodrome to the rash stage. And then the outcome can be resolution or repeated scarring of the lesions. However, as we mentioned, there can be complications up to 40%, such as your secondary bacterial infections, pulmonary involvement, severe dehydration, encephalitis, corneal scarring, and death. However, in the 2022 outbreak, the features show that patients only have minimal or mild prodrome. Rash involves primarily the genital and the perianal areas, and majority of the cases among men have sex with men. In the descriptive case series by Thornhill, published in Lancet, they had 528 participants where they noted that were of which 70 of them were hospitalized. 5% of the participants were given antiviral. Of those who were hospitalized, um, most of the reason of their hospitalization is really the pain. So they needed pain management for severe anorectal pain, and they also have cases that had soft tissue superinfection, pharyngitis, eye lesions, acute kidney injury, myocarditis, and infection control process. All these participants recovered in this case series. And then another case study from Patnell showed 197 participants who all had mucocutaneous manifestations. 25 or 12.7% were hospitalized, and the 10.2% or the 20 of the participants were admitted for clinical reasons. Still, pain management was the reason. Tonsillar abscess was noted, urinary retention, superimposed bacterial lower respiratory tract infection, disseminated lesions, and they had a report of one case that had perforated rectum. 15 of the participants were known to have HIV. Of these 197 participants, no reported deaths, and there was no one required any organ support. How about the mortality? As of September 14, 2022, 57,000 confirmed cases are already reported with 22 deaths. Calculating the mortality rate, it is about 0.04%, which is significantly less than 1 to 3% that has been reported during outbreaks caused by the similar viral strain in West Africa over the past 2 decades. So the cases are usually severely immunocompromised, such as those that were reported in the US and in Mexico. Some had um, other serious illness, and 2 cases of encephalitis were reported with no risk factors in Spain. Encephalitis can be expected in most viral infections, so um, this is not. So in summary, the spread of monkeypox in 2022 is mostly a human-to-human transmission with close contacts. A typical presentation can be seen in some cases. The best treatment is still supportive care. Vaccine is available but offered only to high-risk groups for now. Preventive measures still is to continue rapid identification of probable cases and isolating contacts to stop further transmission. Most cases are managed as outpatient, but majority are admitted for pain management. So these are my references. Thank you so much for listening.